Sandy. We're going to talk about outdated clinical approaches. How can interdisciplinary care teams and integrated care models be optimized to better address the specific needs and gaps in the management of patients? And what are some successful examples of these models in practice?
So when I think of outdated clinical approaches, I think of things like older chemotherapy regimens or ways that we used to manage toxicity that have changed. So for example, when I started doing this 20 to 25 years ago, we had two drugs and that was it. There was nothing else really. And you could throw some other chemotherapies, but really now we have approved agents that have improved survival. So we need to make sure we're using the right thing. And then I think the other flip side of that is our ability to manage toxicity. Again, we have much better ways to manage things like nausea, things like neutropenia, even fatigue. We have better ways of predicting and managing these things now than what we used to have. So we need to make sure that our supportive care is also maximized so that the patients can stay on treatment. Because small cell lung cancer is one of the diseases where treatment is really important, that they're getting as much of the chemotherapy as possible and on time. Whereas in non-small cell lung cancer, I may be a little bit more okay with them taking a trip or being delayed or things. But because this is such a chemosensitive disease, it's really important for us, if they want to be aggressive, to make sure that we are maximizing our toxicity management. Otherwise, they're not going to be able to get these treatments, and that's going to definitely worsen their outcomes. I think also is discussing goals of care with patients. And I think there's been a big push in the past 10 years with the early palliative care integration into our lung cancer practices. This is another thing that's really important here, that we are having real conversations with our patients about the goals of their care. With extensive stage small cell lung cancer, our average survivals are a year or two, even with treatment. So, I don't need to say to a patient on the first visit, like, this is the exact numbers, because I don't want patients to perseverate over exact numbers. But I also think it's important to say, this is something that we can't cure and we're going to try to manage it as long as possible, but it's an aggressive disease. So, what's important to you? What are the goals that you would like to see? And that would give an open-ended question for patients to say, well, I'd like to be alive in 10 years for this. And when they say something like that, that might be an opportunity to say, well, I hope that can happen, but I'm really worried with what we know about this disease, that might not be, realistic. So what do you think in the short term your goals are? And that might be an open-ended question too, where they might say, I don't want to be sick or in the hospital. That's really important that I'm at home or that I can do this or that. So this is a disease where we've been really well trained just in the past 5 to 10 years about how to have these discussions with patients. That I would say 20 years ago when I started, we weren't, I don't think personally I was as good at having these conversations. And I don't think we were as well trained in the profession at this. And we found that this has been extremely helpful for a good patient-provider relationship, as well as patient-centered care then, where they're making decisions along with us.
Thank you, Ms. Sandy. And certainly as we talk about how to empower our patients, that shared decision-making that you talked about and incorporating goals of care is incredibly important. Dr. Seetharamu, do you have anything to add with regard to shared clinical decision-making or any other advances or things that address outdated treatments?
Yeah, I can emphasize how important it is to have the goals of care discussion. But I think, even though the treatment regimen has not changed for first line much, there have been some nuances to it, right? We are, routinely including immunotherapy in first line. We now have some supportive care. Trilaciclib is something that we use for patients to help support and prevent admissions These are things that may not be done, and there are some insurance barriers. Trust me, we are on the phone a lot of times that we shouldn't be, trying to get something approved despite clear benefit and FDA approvals. So yeah, that's a barrier that I should have spoken about, probably number one. But that aside, I think that's one thing that we see that is done a little differently in the community. I spoke about tarlatamab. Many people just jump to different treatments because they just feel like they're not able to offer these newer treatments because of inpatient monitoring or what have you. So they may just start from a platinum etoposide to giving them again the same regimen, or jumping to topotecan, which we know that there can be better regimens than that. There are some newer agents that people may not. I've seen that in underutilization of some of the now newer. We don't have a lot of approvals in the space, but even the ones that have been approved, there's a relative underutilization of it. So I think education of providers in the community setting is helpful.